Hi everyone, welcome back to Med-Surg Mentor. Today let's review a topic from a respiratory system, which is bronchial asthma. It is a very common inflammatory disorder of the airways that leads to recurrent episodes of wheezing, chest tightness, and dyspnea. Let's get started. First of all, let's see the incidence of bronchial asthma. Based on the statistics of Asthma and Allergy Foundation of America, approximately 25 million Americans have asthma. This equals to about 1 in 13 Americans, including 8% of adult and 7% of children. Asthma is more common in adult women than adult men. Definition of bronchial asthma. Bronchial asthma is defined as a chronic inflammatory disease of the airways that causes airway hyperresponsiveness, mucosal edema, and increased mucus production. Exposure to various irritants can trigger the allergies. These irritants are called asthma triggers. Common asthma triggers are airborne allergens such as pollen, dust mite, mold spores, and pet dander, respiratory infections, physical activity, cold air, gastroesophageal reflux disease, strong emotions and stress, air pollutants and irritants such as smoke, medications like non-steroid anti-inflammatory drugs and beta blockers, and sulfates and preservatives which are added in some of the foods and beverages. Next is risk factors of bronchial asthma. Common risk factors are family history of bronchial asthma, being overweight, people with smoking habit, exposure to secondhand smoke, pollutants, and occupational triggers. Now let's move on to the classification of bronchial asthma based on frequency of signs and symptoms. It is classified into 4, and they are mild intermittent, mild persistent, moderate persistent, and severe persistent. First category is mild intermittent. It means there are mild symptoms up to 2 days a week and up to 2 nights a month. Whereas mild persistent means symptoms more than twice a week but no more than once in a single day. Next is moderate persistent. It refers to the symptoms once in a day and more than one night a week. Last one is severe persistent, which means there are symptoms throughout the day, on most days, and frequently at night too. Next is pathophysiology of bronchial asthma. Due to the triggers like airborne allergens or stress, there is release of inflammatory mediators such as histamine and leukotrienes. It leads to acute inflammation which is reversible. It is manifested as bronchospasm, bronchial edema, increased mucus production, and airway narrowing. It results in clinical features like shortness of breath and chest tightness. By the enhanced presence of inflammatory mediators, there is hyperresponsiveness for the airway, which can directly induce bronchoconstriction and release of more inflammatory mediators. Finally, it results in chronic inflammation, remodeling, and irreversible damage to the lungs. Common clinical features of bronchial asthma are dyspnea, wheezing, cough, chest tightness, cyanosis, increased perspiration, and use of accessory muscles for breathing. Diagnostic measures of bronchial asthma. Prominent physical examination findings are tachypnea, wheezing, cyanosis, increased nasal secretion, and use of accessory muscles. Next is other common diagnostic measures to rule out bronchial asthma. Common tests are spirometry, peak flow test, methacholine test, nitric oxide test, X-ray, blood and sputum test, and provocative test. Let's see each one in detail. Spirometry test estimates the narrowing of the bronchial tubes by checking how much air can be exhaled after a deep breath and how fast the patient can breathe out. Whereas peak flow test measures how hard the patient can breathe out. Next one is methacholine test. Methacholine is an asthma trigger. When inhaled, it causes slight airway narrowing. So if there's a reaction to methacholine, it's likely that patient have asthma. Third one is nitric oxide test. It measures the amount of gas nitric oxide in the breath. When there's an airway inflammation, there is higher than normal nitric oxide levels. Fourth one is X-ray. It can be done to identify any structural deformities or abnormalities within the lungs. Fifth one is sputum and blood test. These are done to identify levels of eosinophils, which is a type of white blood cell that can cause bronchial asthma. Sixth category is provocative test. These are done commonly to identify exercise and cold-induced asthma. In this test, the airway obstruction is measured before and after vigorous physical activity or several breaths of cold air. There is one more test to rule out bronchial asthma, and that is skin test. This is done if there is a doubt that a specific allergen is causing the asthma symptom. It is a quick and reliable method. Here, a dose of possible allergen is injected through the skin prick and tracks the body's response to it. Usually, a dime-sized hive that is red and itchy are considered as allergy. Also, high levels of immunoglobulin E or IgE can mean that one is having allergy to that specific allergen. Complications of bronchial asthma are status asthmaticus, pneumothorax, hypoxemia, acidosis, respiratory and cardiac arrest. Next, let's see the common medical managements for the treatment of bronchial asthma. The first category is quick relief drugs. They include short-acting beta agonist, anticholinergic agents, and intravenous corticosteroids. Other medications are corticosteroids, leukotriene modifiers, combination inhalers, theophylline, and anti-allergic drugs. I have given examples of each of them for your reference. Bronchial thermoplasty. It is a new, innovative, non-drug procedure for the treatment of severe persistent asthma. In this procedure, under sedation, a catheter inside a bronchoscope is introduced through the patient's nose or mouth into the lungs. It delivers thermal energy into the thick and smooth muscles on the inside walls of the airways, thus helping it to open up. This medical procedure helps to improve the asthma symptoms. Nursing care of patient with bronchial asthma. Assess respiratory status and oxygen saturation. Provide adequate rest. Identify and avoid allergens. Encourage to do deep breathing and coughing exercises. Ensure hydration. Administer bronchodilators. Nebulize the patient as ordered. And administer supplemental oxygen. So far we have seen regarding bronchial asthma. It is a chronic inflammatory disease of the airways that causes airway hyperresponsiveness, mucosal edema, and increased mucus production. We have seen the definition, etiology, pathophysiology, clinical features, complications, classifications, diagnostic measures, management, and nursing care. Thank you so much for watching and see you next week with a different interesting topic from medical surgical nursing.